Good morning. Welcome back to Government School. The last session we have discussed about the classification of migraine in mainly migraine with aura and without aura. Today I'll be discussing the acute management, otherwise called the abortive therapy for migraine. Let us look into the general principles. The choice of acute therapy depends upon the severity of the attack. Is very important. Presence or absence of nausea and vomiting. Third, whether it is at home or in the emergency department. And most important, whether the patient has got any cardiovascular comorbidities. The core general principles are: one, treat early. Adequate early dose is better than repeated small doses. Third, tailor the route. This depends upon nausea and vomiting. And add prophylaxis if indicated, so that recurrence can be prevented. So now we think about a patient with a mild attack without severe nausea and vomiting. The first line treatment is non-opioid analgesic. I will repeat, non-opioid analgesic. We can give Ibuprofen 400 to 800 milligram, Naproxen sodium 500 to 750 milligrams, or acetaminophen or Paracetamol 1000 milligrams. Remember, they are effective, widely available, and well tolerated. So that is the advantage of starting a non-opioid analgesics. If there is no adequate response, add a triptan. The combination of a triptan plus NSAID is more effective than either alone. And now go to a moderate to severe migraine. The treatment should be triptan plus NSAID. As mentioned, you should give a combination therapy. Examples are Sumatriptan 50 to 100 milligrams orally, or if the patient cannot take, you give Sumatriptan 6 milligrams subcutaneously. We can give Rizatriptan 10 milligrams. All triptans are effective. As I mentioned earlier, combination therapy is better and should be started. If there is severe nausea and vomiting, what you do, give metoclopramide 10 milligram as a parenteral, intramuscular or intravenous, or you can give prochlorperazine, or switch over to subcutaneous triptan, that is 6 milligrams of Sumatriptan, or give nasal triptan. Okay. Then what are the alternative options? I will discuss this separately. One is CGRP antagonist, 5-HT1 agonist, and dihydroergotamine. This will be discussed separately. These are given when triptans are contraindicated or ineffective, severe attack in the emergency department, or a refractory migraine. The suggested combinations are: one is subcutaneous triptan, Sumatriptan 6 milligrams, parenteral antiemetic, sample metoclopramide 6 milligrams, 10 milligrams intravenously. We can give adjuvant therapy, diphenhydramine 25 milligrams to prevent extrapyramidal side effects, that is dystonia due to metoclopramide, and dexamethasone 4 milligram intravenously or intramuscularly is also suggested. Alternative options in the emergency department are: one is IV dihydroergotamine. If no triptans have been given during the last 24 hours, not this point, if the triptans were given during the last 24 hours, never give IV dihydroergotamine. IV sodium valproate is frequently used, and IM or IV ketorolac. These are the alternatives. And now we think about status migrainosus, that is migraine lasting more than 72 hours. The suggested approach is give adequate hydration, give IV fluid, IV ketorolac, dopamine receptor blocker like a prochlorperazine or metoclopramide for nausea and vomiting. Other options, as mentioned earlier, can be IV sodium valproate, IV dihydroergotamine. and admission may be required in cases. So, simple clinical algorithm: mild, you give NSAIDs; moderate, you give combination Triptan plus NSAID. If nausea and vomiting is there, give an additional antiemetic. In refractory cases, you give subcutaneous Sumatriptan, IV antiemetic, dexamethasone, and other alternative treatment like sodium valproate and dihydroergotamine. More than 72 hours, there is migrainosis, you go for IV and combination therapy. The key points are: avoid opioids, early treatment, combine classes of drugs whenever required, and give preventive medications. And again, remember, this abortive therapy should not be given more than 10 per month. So, the next session, we'll be discussing about the prophylactic therapy. Stay tuned. Thank you.